Welcome to Understanding Chest Tubes. Before we get started on the actual chest tubes themselves, we're going to quickly talk about the thoracic cavity. And so this is really important that you have a good understanding of what's within your thoracic cavity. That will help you understand how chest tubes work. So if we were to open the thoracic cavity and take a look inside, we have, of course, the right and left lungs, and we have the mediastinum. It's this area here, and the mediastinum houses the heart, the aorta and great vessels, and of course the esophagus and the trachea. Anytime you do interventions or surgery on any of the organs within the thoracic cavity, you will need a chest tube inserted to evacuate any air or fluid from within the thoracic cavity. The next thing that's important that you understand, have a good handle on before we progress to chest tubes, is the mechanisms of breathing. So on inhalation, the diaphragm contracts, it moves down, increases the volume within the thoracic cavity. As the volume increases, the pressure inside decreases, and therefore we will be pulling air in or sucking air in from the atmosphere. So the air will move from an area of high pressure in the atmosphere to an area of low pressure within the lungs. Okay, so that's really important to remember that on inspiration or inhalation, we generate negative pressure. On exhalation, the phrenic nerve stimulation is stopped, the diaphragm relaxes, it moves up, and air is passively pushed out of the chest, basically. And so we have positive pressure on exhalation. The next thing that you need to understand is what is the pleural space. So within the thoracic cavity, there is a very thin membrane called the pleural membrane. It lines the chest wall, and that's called the parietal pleura. And then it basically folds over on itself and lines the inner organs, and that's called the viscera pleura. Between those two membranes, there's a very small space called the pleural space. There is generally a small amount of negative pressure within that pleural space to keep the lungs expanded and the two membranes sort of stuck together, if you will. There's a small amount of fluid in there that lubricates the membranes, and so that when we breathe in and out, they slide back and forth quite nicely on each other. Whenever we get air or fluid within the pleural space, the membranes become inflamed, breathing becomes difficult, the lung volumes are compromised, and therefore the patient's respiratory function is compromised. So the goal is to remove the air or fluid from the pleural space, and we do that with a chest tube. So there are many reasons why we put chest tubes in. So the first is a pneumothorax, which is air within the pleural space. There's a hemothorax, which is blood within the pleural space. An empyema, which is pus or purulent discharge within the pleural space. The pleural effusions, which are basically buildups of fluid, serous fluid within the pleural space. A thoracotomy would be another reason why we would put a chest tube in. And for a thoracotomy, that again is an opening of the thoracic cavity. So anytime we do surgery on those organs involved or housed in the thoracic cavity, it's called a thoracotomy. Bronchopleural fistula, so this occurs when, for example, a patient becomes a chronic aspirator and they've aspirated food into the bronchioles. It becomes necrotic, the tissue becomes necrotic, and a fistula develops and it communicates between the bronchiole into the pleural space. We have penetrating wounds, so this is our gunshots, stabbings, impalements, also our surgeries. And the last one is a chylothorax, and a chylothorax is a buildup of lymphatic fluid within the pleural space. So basically it comes down to air or fluid within the pleural space. Those are the indications for a chest tube. We're going to talk about a pneumothorax. So pneumothorax is again air within the pleural space. It can be subdivided into three general categories. So the first one is a closed pneumothorax. And all that means is that the chest wall or the thoracic cavity is intact. The chest wall is closed to atmospheric air. So therefore, the rupture, the hole, is within the lung tissue and the visceral pleura. So you can see it here. There's a rupture within the lung and the air is leaking into the pleural space. If it's left unattended, the air will build up, the pressure will increase, and the lung will completely collapse. Here's a chest x-ray visual of a pneumothorax, and you can see here the dark space. This is air, and this is the lung border here. Now, if you look at the mediastinum, it's shifted a little further over to the right than we would like, and you can also see a bit of shadowing here, which is air building up. So this is developing into what we call a tension pneumothorax. One of the outward signs of a tension pneumothorax is tracheal deviation, so it deviates over to the opposing side. Tension pneumothorax can be fatal to our patient if it's not dealt with in a timely manner, so it's really important to be aware of its possibility. So basically, chest wall is intact. We have a pneumothorax, closed pneumothorax, air is leaking, pressure is built up to the point where it starts to shift that mediastinum over. The trachea deviates, the vessels are pushed over, and the pressure builds up so that it compresses those vessels and no blood returns to the heart. No blood, no cardiac output, and our patient will go into a cardiac arrest. So very dangerous and must be dealt with in an urgent fashion. The third type of pneumothorax is an open pneumothorax, and it simply means that the chest wall is open to atmospheric air. So with our patient here, you can see a stab wound penetrating through the chest wall. So this would become an open pneumothorax, particularly when the knife is removed. So our penetrating traumas, gunshot stabbings, impalements, surgery create open pneumothoraxes. An open pneumothorax is also called a sucking chest wound. Basically, it sucks air through that hole in the chest wall. They look bad, they sound bad, but in reality, they're not as bad as a closed pneumothorax because the air can vent, so it stops the pressure from building up and a tension pneumothorax from occurring. Where these become fairly serious is where we close the chest wall with an occlusive dressing. So if we were to put a sterile gauze with, say, waterproof tape that doesn't allow air through it over the entire gauze and tape it down on all four sides, it essentially closes the hole. So no air can get into the chest. If there happens to be a hole in the actual lung tissue, air will continue to leak within the thorax, and a tension pneumothorax will occur. So when we're closing an open pneumothorax, we put our occlusive dressing, but we only tape it down on three sides so that the one side can lift away from the chest wall when the diaphragm is pushing the air out, so air can still vent. When you breathe in and you generate that negative pressure, you will suck the occlusive dressing over the hole and prevent air from entering the chest. So that would be how you deal with an open pneumothorax. Hemothoraxes and pleural effusions are again fluid. It's important to remember that fluid is responsive to gravity, so fluid dependent. It sinks to the bottom and to the back and typically accumulates here at the bases of the lung fields. So when you auscultate your patient, you're going to have decreased or absent breath sounds. They're going to be short of breath because lung volumes are going to be compromised, and those membranes are going to be really inflamed and they're going to rub on one another, so they're going to have pain on deep inspiration. The treatment for all of these conditions is to remove the air or the fluid as promptly as possible. We want to prevent it from returning to the pleural space, and we want to restore that negative pressure within the pleural space to re-expand the lungs. We do that with, of course, the insertion of a chest tube. Now, the equipment needed for this is the thoracic chest tube. That's the actual tube with the holes or the eyelets at the end that is inserted through the chest wall. We have the chest tube drainage unit, which typically tends to be a disposable unit nowadays. It connects to our thoracic chest tube. We need wall suction if it's ordered, and all of the tubings and connections to make the system work. Chest tube insertion is an invasive procedure, so we do need an informed consent. Now, if this is an urgent procedure and we're dealing with a tension pneumothorax, the physician or the nurse practitioner who's putting the chest tube in will do what's called a two-doctor consent, or will have two medical personnel sign saying that it is deemed medically necessary. You want to make sure that your patient has some analgesic on board if they can tolerate it, because chest tube insertion can be quite painful. We want to have a good set of baseline vitals so that we can compare post-insertion to make sure everything is stabilizing. We're going to gather all of our equipment, our chest tube, drainage unit, connections. We get a chest tube insertion tray, and on it has all of the equipment that the physician will need, and of course get the sutures. We need a bottle of sterile water to keep at the bedside, and we're going to talk a little bit more about that later. And after the chest tube is inserted, there must be an x-ray done to make sure that it's in the proper place. I just want to talk a little bit about the actual chest tube, or the thoracic cavity or the thoracic catheter that is inserted into the thoracic cavity. The tubes vary in size. They can be very small to very large, about the size of your finger. And so the bigger tubes are to drain blood or fluid. Smaller tubes are for air. So you want to make sure you ask the physician or the nurse practitioner what size of tube they would like to insert so that you have the appropriate one. So it really depends on why we're putting the chest tube in. Are we draining air or are we draining fluid? So here we've got the tubes in situ. This one's around the third intercostal space. This would be for air. Remember, air rises, so it'll come to the front of the chest and to the top, which is why the chest tube is angled up here. This one would be around the sixth intercostal space, and that would be to drain fluid, so your blood or your effusions, because gravity is going to send it to the bottom and to the back. When chest tubes are inserted, it's quite uncomfortable for a patient, and this is sort of a step-by-step, so you have a good idea of what happens. This can be done at the bedsides with a nurse assisting, and so basically you put some lidocaine or some freezing. The patient's awake for the procedure, they're not anesthetized. So once the freezing's in and working, they're going to take a scalpel and make a small incision. Through that incision, they're going to push a Kelly clamp to go through the muscle, the intercostal muscle, into the parietal pleura. So if you take a look at where this Kelly clamp is, you will see that it's riding right on the top of the lower rib, and that's really important because on the bottom of the upper rib will run blood vessels and nerves. So if the physician or the nurse practitioner were to situate that chest tube too close to the blood vessels and the nerves, the tube can wiggle and erode through the blood vessels. The patient can have a hemorrhage, or it can irritate that nerve, and your patient's going to have quite an intense amount of pain on inspiration and expiration. So the situation of the chest tube is important. Once they get that Kelly clamp through, they're going to open it up to spread the muscles to make a hole. They're going to take it out then and insert their finger. So right through, they can feel that they're through the parietal pleura and sort of make a pathway for their chest tube. They want to do that with their finger because it has tactile sensation. It's not just a blunt, sharp, or a sharp object that's going to tear tissue. Once they've done that, they're going to feed the tube into place. So here's a pictorial representation of a chest tube being put in, and you can see that they do actually insert their finger quite far into the pleural space. So you want to make sure that you have good analgesic for your patient. Here they're inserting the chest tube. And the final picture here, it's sutured in place. The type of suture that's put in is what's called a purse string suture. And basically, it's very similar to the string in a gym bag, if you will. It's tied, it goes through the tissue around the tube, and the two ends are left loose. And if you pull on them, it cinches the tissue up around the tube, and then it's tied to the tube. There's no way to actually suture through the chest tube without causing a leak. So basically, the tube is just cinched into place. And if it's tugged, it could dislodge. So when the nurses put the dressing on, you want to make sure that it's on quite tightly to help support that chest tube and hold it in place. And then we attach our chest tube drainage unit, and this is very old school, 3 glass bottles, but it highlights the 3 chambers quite nicely. So this would be the tube that's coming from your patient or connect to the actual thoracic cavity. Any fluid or blood that drains from the patient will drain into this chamber. We want to keep it below the level of the patient's chest so that nothing can return into the patient. Any air that drains from the chest tube will pressurize this bottle, rise up through this tube here, and come down through the straw and bubble out under the water. So this is what's called our water seal chamber. Essentially, the air can leave, but it cannot go back through the water into the patient. In modern day chest tube drainage units, we have a one-way valve. Some still have a water seal chamber that you need to fill and maintain with water in it. So it's important to know the type of system that you have. Is it a dry seal with a one-way valve, or is it a wet seal with a water seal chamber? The third chamber here is our suction regulator. This is attached to our vacuum source or our wall regulator. It's typically set around 80 millimeters of mercury on the wall regulator, but the actual amount of suction that applies to the patient is regulated by how much water is in the bottle. So it needs to be ordered by the physician or the nurse practitioner, and it typically goes between 0 and 40 centimeters of water. So depending on how much water is in the bottle is how much suction is applied to the patient. It's important to remember how our mechanisms of breathing help at this point, right? So on expiration, we have positive pressure happening, so the patient can help evacuate that air and fluid by deep breathing and coughing, performing a Valsalva maneuver, and that helps push all the air and the fluid out of the chest. Gravity works on the fluid, right? As long as the chest tube drainage system is below the level of the chest. If suction is ordered, it can help speed the process by pulling the fluid and the air from the chest. So this is a picture of sort of our modern day chest tube drainage units. This one has the collection chamber here, comes from the patient. There is the water seal chamber. Now many of them have what looks like a water seal chamber and a one-way valve. So the one-way valve evacuates the air, but it also comes through this air leak meter, if you will, and allows us to see it bubbling. And then our suction regulator here. Now this one you actually have to put the fluid in, and you can see it here. This column of fluid would be 20 centimeters, and that would apply our water suction. Some of them have a regulator on them where you simply turn the dial to the set amount and it applies the appropriate amount of suction. Those ones have a small orange bellow on the front, and when the bellow is expanded, it means that the suction is functioning. It is important to keep that chest tube drainage unit below the level of the chest, allows a pressure gradient to be there and the fluid to flow from the chest down to our chest tube drainage unit. Here's a picture of the air leak meter, and so if you have a one-way valve, you will still have this air leak meter. It allows us to see the air escaping. So if your patient has a resolving pneumothorax, we should see the bubbling on expiration. So when that diaphragm moves up and pushes the air out, we should see bubbling. it should be intermittent bubbling. If we see continuous bubbling in the air leak chamber, so on inspiration and expiration, that tells us that there is a system leak happening. We need to find it and fix it. Typical places for air leaks to occur are at the insertion site, so you need to redo your dressing. It can be at the connection between the thoracic cavity and the chest tube drainage unit, so we typically tape those with waterproof tape. Or it can be somewhere within the chest tube drainage system itself, and for that we typically replace it. So we should only see intermittent bubbling on expiration. We should never see continuous bubbling. Assessment for our patients is really important when they have chest tubes in. There's lots of different acronyms that will help you remember what to assess. I prefer to use PATCH because it starts with patient, and our patient is the most important part. So PA is patient, T is tubing, and CH is the chamber. So we move from the patient down to the chest tube drainage unit. So assessment for our patient, we should be doing level of consciousness. One of the first signs of hypoxia is a change in level of consciousness, so we want to be looking at that. We're doing vital signs, and we're making sure that our patient isn't becoming tachycardic or tachypnic. We're looking at work of breathing or respiratory effort. So what's the rate, depth, ease of respiration? Is there any indrawing happening? Are they short of breath? Do they have a cough? And if they have a cough, are they producing any sputum? Deep breathing and coughing is good for people with chest tubes. We don't want those lungs to be half inflated with sticky sputum within them. We want to get that out. We're looking also at chest expansion or chest excursion. Is it symmetrical? Right? Is our pneumothorax or hemothorax resolving and we're having equal chest expansion? We're also listening to breath sounds. Do we have breath sounds on both sides? Are they diminished? Are they absent? What's going on there? We're looking at skin color. We don't like to see any signs of cyanosis. Position our patient to facilitate drainage. So semi-Fowler's position with the affected side up would drain air. Semi-Fowler's with the affected side down would drain blood. So it's important that we know what are we draining. If we're draining both, we want to be turning our patient Q2H and getting them deep breathing and coughing to facilitate that drainage. Pain is important that we manage pain because these chest tubes can be quite painful for people, and then they're going to take small, shallow breaths and they're not going to re-expand those lungs. We're looking at tracheal position because remember, tracheal deviation is an outward sign of a tension pneumothorax. We're looking at the dressing. Is it dry and intact? We want to make sure that when we're changing, we have a physician's order for that. We're looking for excessive bleeding at the site. That can be from within the actual chest cavity, or it can be at the insertion site. If that chest tube has eroded through the blood vessels on the bottom of the intercostals, we could start to see a lot of bleeding happening. And we're also looking for subcutaneous emphysema. So that's air leaking into the subcutaneous tissue, and it typically feels like bubble wrap. Now we're on to the T tube. So we're looking at the site of the chest tube insertion, and we're looking, listening, and feeling. So we're looking to see, is the suture intact, or is the catheter all the way in? We shouldn't see any eyelets or any of the holes within the chest tube sticking out on the outside of the chest wall. We're listening to see if there's any hissing or an air leaking. We'll hear the air leak. And again, we're feeling when we're doing the dressing change to see if there's any subcutaneous emphysema. If it's present, we're going to mark the area. And we're going to follow that tube down to the connection with the chest tube drainage unit. We're making sure that it's taped well. We don't want to have any dependent loops within that tubing, particularly if we're draining blood. The blood can clot and obstruct the tube. We don't want the tube to be clamped. They often come with a clamp from the manufacturer. Some facilities request that you remove it If you don't remove it, you want to push it all the way to the end where the tube is not collapsible so that it doesn't inadvertently become clamped. Old school practice is to do what's called milking and stripping of the tube, and that's where you squeeze the tube and tug downward. This is not best practice anymore. Basically, it can cause excessive negative pressure within the chest. Studies have shown that it can generate pressures of up to 400 millimeters of mercury, and that can cause a tension pneumothorax, can biopsy lung tissue into the eyelets of the tube, so not recommended. And then CH is chamber, so we're on to the collection chamber with our assessments now, and we're looking at how much fluid is there, how much is draining, what color is it. We can have, if we're draining blood, anything from bright red or bright sanguineous to an old dark blood. Any bleeding that is greater than 100 mils per hour is considered a hemorrhage, and you want to notify the physician or the nurse practitioner of that. Now keep in mind, if your patient has been laying on the opposite side all night and sits up or changes positions, you may have a large amount of fluid drain and simply with position change, but it shouldn't be bright red blood, it should be old blood, and it should diminish quite quickly. When the collection chamber is full, there's no need to try to drain it or empty it. We simply change it with a new one and dispose of it in the biohazard. We want to make sure that we're documenting the amount of drainage in our collection chamber on our ins and outs every shift, that the suction is set at the ordered level, and that our wall regulator is set at a minimum of 80 millimeters of mercury pressure. If you have that orange bellow expanded, that tells us that the suction is working. If it isn't all the way expanded, you can increase your wall regulator suction so that the bellow expands appropriately. And then we're monitoring that air leak meter for bubbling. We should only see bubbling on expiration, right? Intermittent bubbling. And we should see what we call tidling or fluctuating. And that's the fluid in that air leak meter fluctuating up and down the column as the patient breathes in and out. And it basically is responsive to changes in the interthoracic pressure. As the pneumothorax or hemothorax resolves, you will see less and less fluctuating. Some troubleshooting to keep in the back of your mind is that the thoracic catheter can fall out. Remember, it's just snugged in there with a suture, so if it's tugged on firmly, it can dislodge. And so if that happens, we want to make sure that we cover the hole with a sterile dressing, and if we make it occlusive, we're only going to tape it down on the 3 sides. Patients can ambulate with chest tubes in. They can be up and they can be mobile, but we want to make sure that they keep their chest tube drainage unit below the level of the chest. We're assessing that tubing draining from the patient to the chamber to make sure that it's patent. Clots can develop over time, and so if that happens, we can compress directly on them and roll back and forth to try to dislodge them, but we don't want to put any downward tugging motion because we would be milking or stripping the tubing then. If the drainage system tips over, if it has a one-way valve in it, we simply pick it up and carry on. If it has a water seal in it, we pick it up and we need to immediately refill the water seal to make sure that air does not enter the patient's chest. If the thoracic tube becomes disconnected from the chest tube drainage unit, they will have the tube through the chest wall, but it will not be connected to anything. It basically becomes a sucking chest wound. And so this is what that bottle of sterile water is for. We're going to open it and put the end of the thoracic tube into the water, and it creates a water seal. The chest tube drainage tubing will have been contaminated at this point, and so we'll simply dispose of it and get a new unit. And the orange Bella we've talked about already. We're going to make sure it's fully expanded to the appropriate mark, and if it's not, we'll turn it up on the wall unit. Other complications to assess for are that sudden increase in bloody drainage. So again, over 100 mils per hour constitutes a hemorrhage. If we have vigorous, continuous bubbling in the air leak meter, that tells us that we have a system leak and we would need to address that. We'll monitor our patient's vital signs for signs of tachypnea or tachycardia with associated shortness of breath because it tells us that there's something going on with our chest tube drainage system not operating properly. So we're going to look for kinks or clots in the tubing, so it would be obstructed. For removal of a chest tube, you want to make sure that your patient has some analgesic, typically a half hour prior to removal, so it's got time to start working. Physicians or nurse practitioners usually remove the chest tubes. They construct a sterile dressing. It's all done under sterile procedures. They untie the purse string suture from the actual thoracic catheter. They'll have the patient take a big breath in and hold it, perform a Valsalva maneuver. As the patient is holding their breath, they're going to remove the tube and then pull the purse string suture to cinch the tissue closed, tie it off, and apply their sterile occlusive dressing. Once the dressing's on, the patient can breathe. The sutures will stay in for 7 to 10 days. Dressing typically stays on for 2 to 3 days until the skin has sealed to itself, and then it can be open to air. The chest tube drainage unit is disposed of in the biohazard. We want to make sure that we're monitoring our vital signs, Q15 minutes, just like post-op vitals, and a level of consciousness and respiratory effort once the chest tube comes out. So we want to make sure that there isn't air leaking in and reaccumulating as a pneumothorax. Patients typically go for a chest x-ray about 4 hours post-removal to make sure that there's no reaccumulation of air. The last thing I want to talk to you about is called a Heimlich valve. It's a small valve that is attached to a very small catheter, and it's typically used when patients have small pneumothoraxes, and they can be quite mobile with these on. If your patients had a central line inserted or maybe a permanent pacemaker, they can often develop small pneumothoraxes as part of the procedure, and so they may put in a tiny thoracic catheter and attach it to a Heimlich valve. It has a rubber tube in it here. When the patient breathes in and generates that negative pressure, the tube will collapse on itself, stopping air from entering the patient's chest, and when they breathe out and push air out, air can come down the tube. This is just a collection unit in case there's any fluid that drains as well, but Heimlich valves are typically used for air. Here's a list of references if you're interested in further reading on chest tubes. Thanks for joining me.